Hello, my name is Luke, and welcome to my presentation on seizures in the pre-hospital environment. Today, we'll take a look at seizure activity, including status epilepticus and refractory status epilepticus. So, having a look at the outline here and some learning outcomes, today we'll explore the pathophysiology of seizures, explore the relevant clinical features and physical examination associated with seizure activity, have a look at the relevant investigations, as well as the appropriate pharmacology and management of seizures, and exploring leadership roles and how best to apply them in this setting. For learning outcomes, we will familiarise ourselves with disease processes, be able to identify signs and symptoms associated with seizures, enhance decision making through those relevant investigations, and advance knowledge on treatment options. Ultimately, we will apply this knowledge to the relevant skills and assessments and be able to mentor other paramedics. So firstly, some definitions and criteria. A seizure is defined as any uncontrolled abnormal electrical activity within the brain, leading to changes in consciousness, cognition, emotional state, and/or behavior. Status epilepticus, or SE, is continuous seizure activity with timeframes dependent on the type of seizure, with 5 minutes for tonic-clonic seizures, 10 minutes in focal impaired awareness seizures, 10 to 15 minutes in absent seizures, or an incomplete recovery in between seizures. So refractory status epilepticus is seizure activity that does not resolve after 2 administrations of the appropriate medication. New onset refractory status epilepticus, or NORS, is a clinical presentation where new onset SE occurs without a history of active epilepsy that is refractory in nature and does not have a clear acute metabolic, structural, or toxic cause. So delving into the pathophysiology. Every individual has a threshold to have seizures, with factors influencing that threshold varying for each person. Some factors include electrolyte abnormalities, alcohol abuse, substance abuse, medication noncompliance, poor sleep, infections, inflammation, injury to the brain, and genetic factors. So the mechanism through which seizures occur are through rapid discharge of cerebral neurons, which in turn discharge connected neurons, leading to a change in their function, and symptomology being based on the area of the brain affected. As seizure activity evolves, it may be reflected on an EEG, with the location and the evolution of the activity accounting for the absence or progression into motor activity and/or status epilepticus. So during a seizure, excitatory neurotransmitters such as glutamate, aspartate, acetylcholine are activated, and the inhibitory neurotransmitters such as GABA are inhibited. This causes an imbalance, leading to the genesis and progression of seizure activity. Calcium, potassium, and magnesium channels are blocked on NMDA receptors, with these receptors also being upregulated, which can further contribute to seizure processes. So with continued evolution of seizure activity, hyperexcitation promotes receptor trafficking, further altering cellular function and leading to reduced efficacy of GABA receptor drugs and poorer outcomes. Where there is excessive excitation and inhibition of these neurotransmitters, prolonged seizure activity develops into status epilepticus. So prolonged neural and motor activity can lead to respiratory compromise, with systemic effects such as increased catecholamine levels, hypoglycemia, electrolyte imbalances, lactic acidosis, which can in turn lead to cerebral edema and poor perfusion, leading to permanent injury. In cases of excessive muscle contraction, this may increase body temperature and increase metabolic demand, leading to the breakdown of myocytes, releasing myoglobulins, which causes hyperkalemia, leading to renal failure. Excessive muscle contraction can lead to muscle failure, including that of the diaphragm and chest wall, causing respiratory failure and respiratory acidosis. And as energy exceeds demand, hypoglycemia and lactic acidosis may occur. The development of arrhythmias and cardiomyopathy may occur from increased catecholamine levels, electrolyte imbalances, and respiratory compromise. As seizure activity continues to evolve, patients will become more resistant to treatment. This is quite significant, as status epilepticus is associated with a high morbidity rate and with short-term mortality rates of up to 27%. Significantly, super-refractory SE has mortality rates as high as 61%. So some clinical features and physical examination. As we've mentioned, this will depend on the location of abnormal electrical activity within the brain, the etiology of the seizure activity if it is known, as well as the duration of the seizure activity. So looking at the neurological system, patients may present with an aura prior to the onset of symptoms. They also may present with an altered conscious state and confusion, particularly if they are post-ictal. They may present with lethargy, staring, coma, psychosis, catatonia, focal deficits, and signs of poisoning and alcohol withdrawal, particularly if this is the trigger for the seizure. Motor function. Patients may present hypothermic, as we've explored. They may present with myoclonic jerks, trismus, nystagmus, eye deviation, or may have the complete absence of movement. Looking at the patient airway, they may aspirate with the loss of patency and protection, though difficult assessments may be due to trismus. Looking at patients' breathing, respiratory failure, hypoxia, and hypercapnia may be present. Cardiovascular system, patients may present with sinus tachycardia, sinus bradycardia, atrial fibrillation or flutter, and ventricular tachycardia and ventricular fibrillation in cases of cardiac arrest, or atrioventricular blocks and signs of hypotension and poor perfusion. The gastrointestinal system, patients may present with nausea, vomiting, and urinary incontinence. Metabolically, they may be hypoglycemic with electrolyte imbalances and lactic acidosis. Patients may also present with infectious symptoms, as these are sometimes the cause of a seizure activity, such as in the case of meningitis, where patients may have fevers, flu-like symptoms, rashes, and migraines. Similarly, in cases of trauma, patients may present with head trauma, tongue bite, and injuries from falls due to the seizure. And similarly, seizure activity may be the result of trauma as well. So some relevant investigations here. Investigations should be performed in a manner that may help to address life threats, identify potential causes of seizure, and remedy the effects of the seizure activity. So significantly, an airway assessment. We must perform a mallapative score and recognize the potential for difficult intubation, particularly in the presence of trismus. We must assess for aspiration and obstruction. Looking at the breathing, auscultation to listen for infiltrates and signs of aspiration. Capnography may help to monitor for respiratory distress or depression, as well as CO2 levels that may reflect respiratory acidosis and signs of inadequate perfusion. Continuous cardiac monitoring and 12-lead ECG to assess for cardiomyopathies and arrhythmias is needed. We must continually monitor vital signs to ensure hemodynamic stability. Where point-of-care testing is available, hypoglycemia should be discovered. Is a potential trigger of seizure activity, as well as can result from the processes of seizure activity. Where iStat is available, the Chem8 cartridge will help to identify electrolyte imbalances, those glucose levels as mentioned, as well as renal function. CGS4 cartridges also offer lactate levels and blood gases. In-hospital investigations may include the use of an EEG, CT, MRI, serum, and CFS studies, which they'll be particularly noted to use in cases of Norse. So having a look at the pharmacology here, midazolam for instance. Benzodiazepines such as midazolam are first-line pharmacological agents for stopping seizure activity. It has multiple indications and is able to be used for terminating seizure activity, to treat refractory status epilepticus, which may be used in an infusion, or for facilitating rapid sequence intubation, or RSI. So benzodiazepines work by binding to postsynaptic GABA receptors, which then work to potentiate the neuroinhibitory effects of GABA, hopefully undoing that imbalance we mentioned in the pathophysiology section. However, midazolam becomes less effective as seizure activity progresses, and the neuroinhibitory effects of GABA are reduced. Some risks for this include misdiagnosis or lack of recognition that the patient is experiencing a seizure, which causes a delay in appropriate treatment. Fortunately, paramedics have quite a high rate of administering benzodiazepines. However, this is often at a lower than recommended dose and through less effective routes, often providing ineffective treatment. An example of this would be prioritizing IV access over IM administrations. Some concerns raised by paramedics in administering benzodiazepines include the risk for adverse effects such as apnea and hypotension, and fears for when IV access cannot be established. Appropriate benzodiazepine treatment is linked with effective cessation of status epilepticus, reducing overall seizure duration, reduced time spent in hospital, and improved respiratory status, as respiratory failure is more likely to occur due to seizure activity. As we've mentioned, muscle fatigue of the diaphragm and chest wall can contribute to this. So midazolam can be used effectively via intramuscular and intranasal routes with comparable efficacy to other IV benzodiazepines. The benefit to this is they may be administered prior to IV access being established. Interestingly though, only 34.5% of patients are treated out of hospital via intramuscular routes, resulting in treatment delays. So ketamine. Ketamine is traditionally used in anesthesia, but has since found other applications. It non-competitively blocks the NMDA receptor and acts as a glutamate receptor agonist. NMDA receptors may also play a role in increasing availability of GABA receptors. This is quite interesting as it has multiple theoretical benefits as a third-line agent in an in-hospital setting, and second-line option out of hospital where there are no physicians available. Similarly, it may be used for rapid sequence intubation. Its efficacy may depend on etiology of seizure activity and early administration. It's more useful in terminating SE or non-convulsive seizures, with reduced efficacy in super-refractory status epilepticus. Studies vary in reporting successes with termination and varies from 73 to 93% in adults and 73 to 100% in pediatrics. Studies that focus on out-of-hospital administration yielded higher results, but with a smaller sample size. Ketamine is not without adverse effects. It may stimulate sympathetic adrenergic effects, but may actually trigger hypotension and bradycardia in patients experiencing prolonged seizures, with a greater risk in elderly populations. So, treatment and pathways. We must immediately address and cease seizure activity to prevent further injury, as well as securing the airway, breathing, and circulation of the patient. This should be performed with first-line agents such as midazolam. Where seizures become refractory after 2 dosages or after 10 minutes, a second-line agent and midazolam infusion should be considered. This may need to be facilitated by a physician-staffed vehicle, such as medical retrieval, where these agents may be carried. After 20 minutes, or if second-line agents are unavailable, third-line agents, such as ketamine, should be considered. In patients who are experiencing respiratory failure, endotracheal intubation and mechanical ventilation is indicated. This may need to be facilitated through rapid sequence induction, which may include the use of therapeutic agents such as midazolam and ketamine. Where seizure activity persists for 35 minutes post-appropriate treatment, general anesthesia and RSI is indicated. Where this fails, particularly in the context of trismus, a rescue airway should be considered. So ensuring airway patency via nasopharyngeal airways and oropharyngeal airways will help to mitigate difficulties for ventilation and oxygenation during periods of apnea and hypoxia. Supplemental oxygen is essential to counteract hypoxia and assist with increased metabolic demand associated with seizure activity, with hypoxia and hypercapnia being common. We must strive to maintain patients' hemodynamics as well as predict adverse outcomes associated with midazolam and ketamine. Hypothermia is a non-pharmacological option which may have some therapeutic benefit in terminating prolonged seizure activity, although this is quite limited supporting evidence and mixed results. Fortunately, though, this may actually help to reduce hyperthermia that is secondary to metabolic demand or infection. We must recognize and treat possible reversible causes such as hypoglycemia and hypoxia. However, there is a need for further research overall in this area to develop appropriate treatment plans and improve patient outcomes. Having a look at the dosages here, we can see midazolam has multiple indications. It's a frontline agent for seizure indication. It should be used intramuscular and intranasal where IV access has not yet been established. We can see here some adverse effects potentially for respiratory depression and hypotension. Midazolam can be used again in refractory cases via infusion if needed, though the risk of adverse effects are increased when given IV. Ketamine can be used where refractory status epilepticus, which is after 2 unresponsive boluses of midazolam, with some adverse effects of hypotension, tachycardia, bradycardia, hallucinations, and sympathetic adrenergic effects. We can see here it can also be used both intramuscular and intravenously, and the dosages are there for you to see. So transport decision making. We must consider urgent transport in these cases, particularly where patients are experiencing SE or are refractory. We must consider the capability for immediate cessation of seizures. With an inability to do so, we should consider the closest hospital for additional pharmacological options. We must also consider the availability of medical retrieval units and other resources, where a lack of manpower may lead you to go to the closest hospital. You should consider the closest hospital where there are threats to airway, breathing, and circulation that you cannot address yourself. Consider some underlying causes such as trauma, which may change your destination. Patients may also require ICU for advanced management, with continued sedation and ventilation if safely transported. We can also consider specialist hospitals that have a neurology department. So having a look at the leadership role. Leaders show the way, and to be effective in doing so, they must have the necessary attributes, skills, and knowledge. Leadership roles may vary based on the situation, as well as with the needs, skills, and experiences of the patient and the colleagues. Having attributes such as creativity and respect, clinicians can empower colleagues through delegation and support to excel in their role whilst increasing situational awareness. So this may include delegation to airway management or overseeing pharmacological administration. Similarly, it may involve the highest clinical level performing a specialist skill and delegating that role of team leader to another clinician. Outside of clinical skills, communication is key to effectively coaching and relaying information whilst on scene. Promotion of open communication ensures that any concerns are addressed and can improve upon patient safety. So having the relevant knowledge coupled with prior experience can greatly assist in being a role model. This includes improving upon your clinical development and recognizing your own weaknesses, which in turn allows for greater ability to provide appropriate treatment. This is particularly relevant as research suggests out-of-hospital management of seizures requires improvement. As well as this, recognizing the need to call for help in the form of MRU, where physician-led units can provide necessary additional treatments when required. Where this is not possible, consultation and communication via clinical advice lines for permission and advice is essential. So thank you for listening to this presentation today.